Hello, everyone. I'm FLAACOs board member Rich Lucibella, CEO of Accountable Cure Options here in the almost dry Palm Beach County, Florida. I hope you're all enjoying day one of the FLAACOs 2020 conference. We'd like to give special thanks to Mark McClellan from the Duke Margolis Center for Health Policy for an outstanding keynote address on the state of value-based care, and also to Farzan Mostashari, Anish Chopra, and Kelly Conroy for their presentation on ONC and CMS interoperability rules. Coming up next is a presentation I think you'll really enjoy. This is Managing Performance Against Payers on One Platform, Dream or Reality. I know at my ACO, it's always been a challenge assembling data from multiple payers all in one place. Here we'll learn how that can be accomplished. And speaking today, we have FLAACOs board member Kelly Conroy from Pinnacle Healthcare Consulting. Kelly has over 30 years of healthcare finance and management experience. She actually started the very first Medicare ACO in the United States, which generated approximately 40 million in shared savings during its first year alone. Over the course of her career, Kelly's been a major player of physician-led, hospital-based, and national ACOs, including having been the executive director for Holy Cross Physician Partners ACO in Fort Lauderdale, Florida. We also have Maria Nicole, a senior business consultant from Salient Healthcare. Maria has over 11 years of experience in healthcare operations and healthcare strategy. Her talents include process improvement and the application of emerging models of healthcare delivery, such as patient-centered medical homes and accountable care organizations. And speaking of patient-centered medical homes, her colleague, Ryan Mackman, will be joining us as well. Ryan's a business consultant with Salient Healthcare, and prior to his time at Salient, he spent 4 years as a business administrator with a level 3 PCMH, Premier Family Health, located in Wellington, Florida. Ryan has a proven track record in business strategy, operations, project management, and analytics. So with that, I'm going to move off camera and hand the controls over to Kelly so that you can focus on this very special panel. Thanks and enjoy FLAACOs 2020. Kelly?
Thank you, Rich. Thank you for the introduction. So welcome to Managing Performance Across Payers on One Platform, Dream or Reality. Today's presentation is filled with a lot of content, hopefully something useful to you and your organization. I tend to talk a little fast, so just so everybody knows, presentations will be available after the conference. Pinnacle Healthcare Consulting is a broad range of value-based strategic, operational, compliance, and valuation services to hospitals, health systems, and physician groups, and other ACOs and CINs, and now direct contract entities across the country. Many of our advisors have served in executive roles in the provider organization, so they have frontline experience. So today we want to talk about the current state and some of the ways you can leverage all payer data on one platform. As we all remember, in 2012, many ACOs started their alternative payment model strategy with the Medicare Shared Savings Program claims and claim line fee, the CCLF data. The first thing we had to figure out back then was what to do with the sea of metadata. Remember those days of CCLF data of billion lines? Understanding which key performance indicators were important to monitor. We've come a long way since then. ACOs and CINs began and continue to partner with payers on shared savings agreements, which also provides claims data and attribution data. With the ever-changing landscape and the inevitable shift to value-based care contracts, more contracts and data sources are being added all the time. The payer data for Medicare Advantage commercial comes in very different shapes and sizes. Many entities struggle looking for the same or similar data across all payers and wish it were synthesized in a clear and efficient way on one platform. So I thought today we could go over a few areas of how having all of your payer data on one platform may help you. The first bucket I'd like to talk about is the actionable and provider level data. That would be scorecards and benchmarks across payers. And then I'd like to just touch on negotiating and renegotiating managed care contracts, shared savings managed care contracts, proving how good your population health really is with your own analytics and data. How nice would it be if you went to the plan and say, and said, we already do 80% of annual wellness visits on our patients. That's a good metric for success. And then I would like to talk to you a little bit about improving your joint operating committee meetings for your commercial payers. And I'll explain what those are in a little bit. And then lastly, extreme and uncontrollable circumstances, being able to quickly pivot and run different analytics. As I take you through some of the best practices of successful ACOs, I would like to share what you are currently doing in 2020. Please share your thoughts or questions in the chat box. FLAACOs has always had a reputation for networking and sharing best practices. And Florida has the largest number of successful ACOs. We are seen as leaders. Now that you have all your data coming into one platform, you can easily prepare actionable all provider scorecards. Be sure that you're prepared to produce patient-level detail should the provider want to challenge this data. You know you have an engaged provider when they challenge this data. And I always like to start with, here is your data on your Medicare Advantage, and commercial population. They like that because if you just take the data on Medicare, it's very, very different for a commercial population. There are timing difference for each bucket, so please look at these reports with me and let me know if they seem right to you. I'd like to just put that out there right away because they will challenge it. And once they challenge it, you may lose them. And anticipate that they will find something wrong with the data, like the patient has passed away or is no longer with the practice. I don't think they fully comprehend how far behind the data is. The providers know their patient panels and have an amazing feel for what's going on. They will help you identify root cause analysis on certain unfavorable trends. Once they start seeing data, especially if it's more than just Medicare, it gets the creative juices flowing and they want more. So some examples of actionable provider level data. I'm going to go over 4 what we call radars here. And if you'd like to know more, please reach out to us for other important KPIs. So the first one I want to talk about is the annual wellness visit radar. Everybody's doing annual wellness visits. So once you have your providers doing annual wellness visits at a rate of 70% every year, I know that's funny to say, but you know, it's very difficult to get an ACO from 10% of annual wellness visits up to 70%, and then it hits them that they got to do that same type of work every year. You may want to watch, this radar is very good for watching it monthly to make sure it doesn't slow or dip. I've seen this happen so many times. We get them up to a really nice successful metric of 60 or 70%, and then the next month it starts to go down. Another thing I noticed that they do is they'll focus on one payer type. Maybe one month their staff will just have gotten the memo on doing them for Medicare Advantage, and then the next month they might be doing them on Medicare. So it's something that you really need to have a radar on and constantly reporting back. Another radar is the transitional care management radar. I find this one very helpful and useful. Often we see a downward trend or large discrepancies between skilled nursing facility and inpatient discharges and the TCM bill. Upon root cause analysis, you may find that the calls have been made, but something fell through the cracks as it pertains to billing. Documenting in multiple systems, or sometimes a manual notification to scheduling or the physician's practice. Next, I'd like to talk about a patient not seen radar. You want to provide care for all patients on your panel, whether they're coming in or not. COVID's a good example of this. One example, physicians are concerned about the COPD patients. They're not coming into the ER, they're not coming into the physician's office. What is happening to these patients? Where did they go? We need to proactively find them, reach out to them and check on them and help them get the care that they need. Next year, we're going to have a large population who have not accessed proper medical care during COVID. So these reports are going to be incredibly important. Next, I'd like to talk about a little bit about provider scorecards for all payers, which may include such things as citizenship points, bonus for extended hours in the evening and on Saturdays, utilization metrics such as inpatient, SNF, and ER per 1,000. And one of my favorites is the ambulatory care sensitive condition admission. This is a metric for patients that are actually admitted into the hospital with an ambulatory care condition. And it is very likely that that patient could have been treated in an ambulatory setting. So this gives you a lot of insight about how that office is practicing and what their workflows are like. Some things that I have found watching these ACFC, we call them, conditions, is that the office closes around Friday at 3 o'clock and sends everybody to the ER. and the patient gets into the hospital with a urinary tract infection, and that surely could have been treated, or at least first stop at the primary care office. These are just a few examples of analytics to monitor success at the NPI level. And they should all be drillable to the patient level for patient level detail. Providers are really starting to get used to having all of this data. It helps them understand what's going on with their population and to provide not just sick care, but preventative care. What are all the other people doing to my patients? Starting to catch on. Next, I'd like to talk about negotiating and renegotiating commercial shared savings agreements. When I negotiate shared savings contracts, I always find that the person with the most information or the best data usually does better. And I want all the analytics run based on our specific needs for our entity. In some negotiations, providers are left using the summation of the data that the plan gives them, which should be validated with your own data. So sometimes this data is very old, somewhere between 1, 2, I've even seen it as old as 3/4. So you're going over this data that's 3/4 old, and you're trying to negotiate your contract going forward. This is why it's extremely important to have your own data, because we do have more current data. So imagine being able to run your own predictive analysis or contract simulation while negotiating on benchmarks per plan, savings over time, trends over time, improvement on quality metrics, and leakage out of network, to name a few. Leakage out of network to specialists is something that typically comes up in a joint operating committee meeting. You can leverage this information to negotiate fair contracts. The plans want to pay you for good and necessary work. It will also help standardize all of your contracts, so you don't have extremely different payer terms, which in turn has a downstream effect on making it easier for your providers. You know, they just don't want to hear, oh, and that one more thing, for this plan, you got to add this metric, or, oh, one more thing, the offices just can't do one more thing. Something that may help you negotiate a better shared savings contract is knowing how much your total cost of care is year over year. Some ACOs contracts split shared savings 50-50 on the surplus. However, if you run analytics on how much you have saved the plan year over year, you'll likely see that that split is much less than 50-50. It's more like you get 30% of the surplus. And that's largely due to other key factors of your managed care shared savings agreement, such as market trends, efficiency factors, and inflation. Having the data and knowing how all of the key terms impact your contract and how they interact makes you a better negotiator. Again, the plans do want this work and will give some high performance, low cost ACOs an efficiency factor to continue to perform well. 2020 is going to be a windfall in terms of the spend. We need to start thinking about this now. In bucket number 3, better joint operating committee insights. If you have a contract with one of the top payers like Cigna, Aetna, United, Blue Cross, you'll likely have a contractual requirement to meet for a joint operating committee meeting once a quarter to review how you're performing. These meetings are often to review data that the plan has rolled up for your ACO or your CIN. It is good to have the same or similar reports to validate the plan's findings before the meeting. Proactively prove your improvements. Remember, the data that they provide for you at the JOC analysis is typically 2 to 3 quarters behind. It's a little hard to make a difference when you're looking at data so old. And also, it's kind of hard to get the data much before, even 24 hours before the actual meeting is a stretch. So having your own data would really help you in this area. So some examples of joint operating committee materials that will help you be better prepared for these meetings are performance index, quartile comparisons, pharmacy data. We all know about the high cost drugs and the brand versus generic, facility utilization, specialty utilization, high cost claimants. It'd be nice to know that the high cost claimants that we run matches with the high cost claimants that the plan shows for us. Sometimes we do find that their numbers aren't right, and we can do a root cause analysis on that. And then lastly, out of network analytics. So lastly, I would like to talk a little bit about unforeseen circumstances. This year is, we could probably put 2020 in the bucket of unforeseen circumstances. So population can help in these extreme and uncontrollable circumstances like COVID. CMS has even said that ACOs and CINs were better prepared, and they plan to double down on more avenues for care coordination. All payer data can help you identify vulnerable patients and enhance care coordination across the continuum of care. This means proactively reaching out to those chronic conditions who are not coming in. We want to keep our arms around our flock, whether they're coming in or not. Remember those COPD patients that the emergency room doctors and the PCPs do not know where they've gone? So some strategies that we're finding during COVID are vulnerable patient outreach, telehealth strategies for sick and wellness visits, quality measures and care gaps, chronic care management, analytics for COVID triage call centers and patient navigation teams. Many ACOs or CINs had to pivot very quickly and set up these call centers to triage patients and to actively reach out to everybody. Before I end, I did want to tell you about one other thing. So transitional care management, not only is it good for the patients, it's good fee-for-service revenue, but we know the transitional care management codes actually reduce spending in an ACO. There was a case study by Salient in Palm Beach ACO several years ago, and then it was further validated by Holy Cross Physician Partners that on average, we save $4,000 per patient post-discharge for a 90-day period when they have received that 48-hour phone call and they've received that TCM visit and it was billed. On average, that's $4,000. And you might wonder, what is that? That is better coordinated care. That's lower readmissions to the hospital. It's a lot of things, but it's just a wonderful thing to watch. And you will be so surprised if you go back and take a look at how many of your nurses or care coordinators made a call within 48 days versus how many patients actually got billed that TCM code. That's something to look for. So anyways, having a robust system with all payers data will help you develop a strong, sustainable process to manage these patients in or out of a natural disaster. Now, I would like to turn this back over to Ryan, and he's going to talk about how Salient has an all-payer solution and what challenges they face with multiple data inputs. Ryan?
And thank you, Kelly. Several years ago, some of you may have seen my colleague, Amy Koch, present on addressing churn in your ACO. Now, in that presentation, she spoke about how one of the causes of churn was Medicare beneficiaries that were leaving for Medicare Advantage. Today, we see that the trends not only continued, but actually increased in pace. And in fact, you can see on this slide that a number of people choosing Medicare Advantage, it's increased every single year since 2006. Now, few states have seen significant MA penetration like us right here in Florida, and you could also see that a good part of the Midwest has had significant MA penetration as well. Now, what does that mean for our ACOs? It means that more and more ACOs are either choosing to or being pushed into taking on more Medicare Advantage contracts in order to continue practicing good population health. Now, we know that this trend is going to continue, but keep in mind, there's a handful of challenges in doing this. When you have many contracts, each with its own rules, regulations, and nuances, you end up having to account for so many variances that scalability becomes a real problem. You also have different data sources, depending on whether your contract is with Medicare, Medicare Advantage, commercial insurance, Medicaid. You're adding more data complexity, and that also means it's a lot harder to monitor performance. Now, in talking about data complexity, or variance for that matter, what I'm going to do now is break this apart into smaller chunks, and we'll discuss where data variances are likely to occur. So first, you have attribution logic. That's a big one. You've got prospective and prospective with retrospective reconciliation. Regardless of what you choose, managing that data can be difficult when you have several contracts, all of which might follow different attribution methodologies. Second, you've got the risk score logic. Some contracts are using CMS's hierarchical condition category. Other contracts might use the Johns Hopkins model, or they might use the diagnostic cost grouper. But if you can't view that information all in one place easily, then at some point, you're going to be stuck downloading all that data into multiple Excel spreadsheets and then trying to make sense of that data, which is kind of like trying to measure something in both the metric system and the American standard system at the same time. It's not an exact match. Third, you've got your quality metrics. Now, depending on your contract and your population, your quality metrics can be very different. Quality metrics for women and quality metrics for men aren't the same to begin with. Then you factor in the different ages and then the different contracts, and you can see how quickly everything gets complicated. Timing is its own challenge. First, you've got to deal with different attribution logic. Then you've got different risk score logic. Then you've got different quality metrics. And then all that information is going to trickle in at different times depending on the payer. So you may have more than 12 downloads in a given month. I'm going to move on now to general data fields. Unfortunately, not all data comes in the exact same way. You have to design templates to fill in a lot of the basic data fields so that you can then do proper calculations. Without that, you really don't have a complete data set. And finally, the sheer amount of data available is extremely variable. For those ACOs who are looking at their Medicare Advantage populations, well, if you want to get an apples to apples comparison of MA against MSSP, then you need to have the same data and the same amount of data coming in. Unfortunately, most Medicare Advantage payers don't provide information in the exact same format that CMS provides for its Medicare beneficiaries, and what that means is somebody has to go back and then fill in all of those gaps. Finally, don't forget the individual contracts that complete the puzzle. So each contract is slightly different, or in some cases, it could be significantly different. Each contract is going to make you adhere to different quality metrics, different attribution logic, and different risk score logic. So these are 11 of the CMS data sources that Salient regularly accesses and brings into our system. Instead of just reading all of these off, you can download these slides at the end of the presentation, and I want to leave some more time for the rest of our team. On this next slide here, we have other data sources, which include some from your multi-payer contracts. There's an HIE. Again, remember, there's different access points to all of these. So honestly, I'd say streamlined is probably the last word that I would use to describe any of this. Now, I'm sure a lot of you are thinking, this is way more complicated than it should be. How do we simplify everything? To do that, you need a single solution that can aggregate all that data from all of the different sources and then normalize it so that you can get an accurate depiction of your different populations, no matter where you're located, no matter what contracts you have. Now, as you can see, that's not easy to do. And to this point, very few solutions are able to pull this off both timely and successfully, which is exactly what Salient does. Okay, with that, give me a second here. I want to change my screen over. And what you should see now is the Salient Healthcare dashboards. And I'm going to be doing a short demo for this part of the presentation because the purpose is to show how Salient can help manage all these data sources, because honestly, talking about it is not the same as actually showing you. I want to preface this portion of the webinar by saying that all of this data is from a demo set. There's absolutely no PHI being revealed at any time. Now, this first page you see here, this is literally the first page that all of our clients see when logging into the dashboards. It's our landing page, and you can see above the widgets that there's MSSP data, and then you see Humana and United Healthcare Medicare Advantage data available. Now, I use those two MA contracts just for the sake of providing an example, but we have the capability to bring in any payer you choose, whether it be MA, commercial, Medicaid, Medicare. It's important to note that there are several categories that Salient organizes, analyze data into in order to provide continual performance improvement. So along the top, you're going to see finance, you're going to see risk, attribution, quality, and utilization. Maria's actually going to dive deeper into those categories shortly. And also here on the landing page, you're going to see those categories manifested in your benchmark. You have your spend to ensure that you're under the benchmark. And you also have your population risk score along with annual wellness visit percentage, which is a proxy for quality. So how nice would it be to show payers annual wellness visit completion percentages across multiple populations all in one platform? Salient also has actionable lists on other dashboards that are going to allow you to get to your data to who needs it when they need it. Now, you're also going to see that there's some red and green highlights. These are directive. They're designed to tell you if you're trending in a desired direction or an undesired direction. In this case, there's no yellow highlights, but if there were, it would represent little or no change. You also have some MA trends available to show you net revenue over time. Okay, next what I'm going to do is use the aforementioned navigation bars here, and we're going to go to the ACO scorecard, and that is there under the financial category. Once this loads up, what you're going to see are 8 individual widgets, and each widget is going to present all the KPIs as a percent change so that you can see how your organization is trending between 2 time frames. So basically what you get here is an organizational report card. In this case, you can also evaluate your MSSP and MA populations against each other for a more accurate comparison. You can see there the ACO, if we're looking at percent change PMPY actual, you see the ACO, you see the United Healthcare there, and you also see the Humana in a similar format to the previous dashboard. So the combined insights from both the landing page and the ACO scorecard are real key for contract negotiations, which is something that Kelly discussed a little bit earlier. So now you've seen we can bring in multiple data sets, and you're really able to get a look at what's going on across your organization, your practices, your providers, your different populations. And I can do that because I can change the way that I'm looking at my data. So if I want to, I can even list out all of my practices. And then again, this is percent change PMPY actual. So simply by expanding this, I can get a look at how all of my practices are impacting my ACO, and I can change this to a more tabular view and get a better look at the numbers. You still have all of those highlights there available to you. If I restore this back down, I also have a series of filters that I can use if I want to isolate any of my data by practice, by provider, by payer, by chronic condition if I want to. So there's a lot of different ways that you can organize and view your data. You can really get to those why questions so that you can implement different initiatives that's going to put your organization in a better position to achieve shared savings. Managing data for patients across all populations can show success through AWVs, TCMs, CCMs. I can even navigate over to the quality overview dashboard, and what that's going to do is give me more information on other quality measures. So as Kelly mentioned a little bit earlier, tracking quality measures is typically an important end of year focus, but Salient can provide you that information year round. So that way your organization can then pivot when it needs to in the event of, say, unforeseen circumstances. We also happen to have a post-acute care overview. And when I bring that up, the post-acute care overview dashboard is there so that you can ask those why questions about the effectiveness of the TCMs that your organization is performing. So when this pops up, you're going to see the Salient platform is extremely dynamic. You're getting patient-level data at the tip of your fingers for each provider, and that can help drive provider engagement and change. Okay. What I'm going to do now is I'm going to hand things off to Maria, and she's going to go ahead and discuss those 5 KPIs that I mentioned a little bit earlier and how Salient goes about aggregating all of that data. Maria?
Thanks, Ryan. All right, so you saw how Salient organizes the key performance indicators in our Salient dashboards, but I wanted to dive into why we recommend that value-based organizations monitor them across all of their contracts. There are 5 main categories that have to be satisfied for value-based organizations to finish with a spend that's below the benchmark and exceed the minimum savings rate to hopefully achieve shared savings. Those categories are finance, risk, attribution, quality, and utilization. For finance, one of the key metrics is to track the spend PMPY versus your benchmark. This is going to tell you whether you're on track for shared savings. With regard to risk, it's always important to keep an eye on your population risk score, both at the organizational level and at the practice and provider levels. Appropriate coding leads to a more accurate benchmark, and that enables you to anticipate the actual cost of care and the type of care that your patient population requires. This is the only way that payers know how sick your patients are and gives you credit for the hard work that you're doing. Now we move on to attribution. We recommend looking at 2 attribution metrics. the percent continuously attributed, and the percent of beneficiaries seen per quarter for primary care services. Based on our experience, those beneficiaries that have continuous assignment typically have a much lower spend. This is likely because they're getting the right care at the right time. Working our way over to quality, we recommend the value-based organizations monitor their annual wellness visit completion rate. This KPI literally impacts all of the other 5 categories. Your organization ultimately benefits as every single quality metric improves. And remember, AWVs reimburse at a higher rate than the E&M visit, and they help to develop a better patient-physician relationship. So this brings us to the utilization category. So first, we look at the TCM percent completed, since completing TCMs can significantly impact unnecessary readmissions. We also look at the visits per 1,000 for acute and post-acute care, and the 30, 90, and 180-day readmission rates. Depending on contract, it really may be helpful to implement initiatives around network management or working with your assignable populations. In network management, organizations may want to work on creating preferred provider networks by identifying specialists that are high value. Your organization will want to track whether your patients are truly seeing preferred providers or whether out-of-network providers are being utilized. If your organization is engaged in multiple value-based contracts, Salient is able to show you your in and out-of-network provider designation that is payer-specific. Many value-based organizations will also receive the assignable patients, not just those that are attributed. The assignable population may be helpful in growing your attribution and size of your organization. Salient has actually developed proprietary logic that helps you identify how likely that beneficiary is to become attributed to you. Now, there's certainly many advantages that our clients derive as a result of the Salient process. First, all of the data is housed in a singular location, which means that there's no need to log into disparate systems or even spreadsheets. Second, it's very easy to compare performance across payers. So for example, you can identify in a single scorecard how your organization is performing across all KPIs, across all contracts, in order to identify areas of opportunity. And third, many times, our clients will receive static reports from various payers. This allows you to validate that information. And given our expertise in the industry, we're able to add a new payer within 8 to 10 weeks, and payers that we're already familiar with, that turnaround time drops to just 6 weeks. Medicare ACO data can be added to the solution in just under 2 weeks. Now, you just saw Ryan show us how quick and easy it was to utilize the data that's available to you. But when your organization receives numerous files, typically throughout the month, it's really easy to get confused if all that data is not centrally located. As you saw in the demo, Salient manages and maintains all the data in one location, and we run timely, continuous data loads for our clients so that you can really get to work on identifying the areas of opportunity for your organization. Salient uses the templating layer, for which the Medicare ACO data is the gold standard. Medicare provides this data in a standardized fashion on a monthly basis. Commercial payers only provide about 70 to 90% of the same data, and that includes some additional fields. We identify the overlapping fields and then use them in the same fashion. Next, we identify any missing data fields in the overall template. In this step, we may identify if other fields can bridge that gap or if that requires developing proprietary logic to accomplish this goal. And finally, we add in the new data field. The new pair becomes part of the overall schema, and that template can now be used for future clients. The template layer provides a systematic method of displaying the data in an apples-to-apples fashion. Now we're going to look at the Salient tech stack that allows us to bring in all of the disparate data sources. I'm going to try to simplify this as best as I can. What you're going to see here is that we bring in claims data, the NPES registry, clinical data, and different payers, which are all part of the data ingestion phase. And again, we bring in as many as you want, but for the sake of slide space, we only use the Medicare Advantage as a placeholder for this example. And remember, this data comes in really at different times throughout the months in diverse formats. Then Salient validates the data for accuracy and quality so that any data conflicts are eliminated. It then goes through the extract, transfer, load process, and that's the staging database where Salient brings in and provides all of the data enrichments. The templatizing and normalizing phase happens here, and during this time, Salient takes in data from the database, organizes it using the Medicare ACO data as the example. And after that we identify those missing data fields that I had mentioned. And then once that template is complete, that's where the last ETL process is, where that information gets housed in the Salient data mart. It then becomes the lifeblood of both SIM and the dashboards, or two different user interfaces. It really takes a lot of work on the part of our tech team to make this happen. And just imagine trying to do this all by yourself. Salient keeps on top of what data is being fed in and when, and then we make sure it's available to you in an easy to read format. So that's how a lot of data and a lot of data sources, and then we make it usable for your organization and your providers. It's really not an easy process, but the end result enables you to manage all of your populations in one place. Wanted to thank everyone for watching FLAACOs 2020 presentation by Salient Healthcare and Pinnacle Healthcare Consulting. We look forward to continuing to help you navigate the ever-changing waters of value-based payment initiatives. We're going to leave this last slide up for a little bit so you can contact any of us directly if you'd like. Also, don't forget to follow us on LinkedIn. Have a great rest of your day, and I hope you enjoy the remainder of the conference.